So future nurses wanted to quickly touch base on Unit 7, Childhood and Neurodevelopmental Disorders. So we covered a lot in class yesterday. Neurodevelopmental disorders have a genetic component, right? We hear a whole lot about how MMR vaccine and autism, Tylenol and pregnancy, there's a genetic link to these. You also see differences in temperaments, and the temperament, that usual attitude and behavior of a child. And honestly, of a person, not just a child, adults too. And we start to see that in infancy. You have some babies that are just calm, quiet babies, and some that are more vocal, right? They have colic. You can see difference in parent and child temperament. You can see problems with attachment. And a lot of times we can see these temperaments early on can predict future problems. So what is resilience? Resilience is that relationship between what your inborn strengths are and how you can handle stressful events. It's your ability to be like, to roll with the punches, to be like, oh, hey, I have a flat tire. This is what I'm going to do to deal with it. And in a child who has resiliency, they can adapt to change, they have good relationships, they have social intelligence, they can read other people's emotions and say like, hey, that person is sad or that person's happy. They have a long-term future. They know like, hey, when I grow up, this is what I want to do. We've talked about ACEs routinely throughout the quarter, right? ACEs, 10 things, if they happen to you when you're a child, you have a higher risk of physical disease and mental illness, right? People with 6 or more ACEs can die 20 years earlier. An eighth of the population have at least 4 ACEs. 66% of the population has at least 1 ACE. So these are huge. So how do we assess a child? Well, we interview, we talk to them, we ask how they're doing. This is much easier in an older child. In any child, we observe, we watch how they're playing, we interact with them, we complete screenings, right? So when you go to your pediatrician with even your kid, they give you that form to fill out. How is your child doing? We need to look at the child, we need to look at the parents, and then we need collateral sources. Is the child only having these behaviors at home with the parent, or are they at school too? There's a babysitter. Do we see with the babysitter? What about at church or a sport team? Developmental milestones are important to know. I know y'all talk about those a lot in pediatrics. You don't have to know them for this class. But when assessing a pediatric patient, we need to know like, hey, this is a 6-year-old who's still only using parallel play. Is that appropriate for them? And then we do a mental status exam. So the mentally healthy child or adolescent sees the world as safe. They're not having hallucinations, right? They can reorient to their own reality. They're hitting their milestones. They're learning new tasks. They're coping with stress, and they're having good relationships. There are different types of therapy in pediatric. Play therapy, using natural play and expressing feelings. Bibliotherapy, books. Art therapy, journaling, music therapy. A lot of it's kind of just what it sounds like. Family therapy is great and super important with pediatric patients because we have to get the parents on board and do some parental training and some therapy with the whole family unit. So interventions, especially on a psych unit, we're going to use teamwork. Our goal is to keep that patient and everyone on the unit safe. We want to use the least restrictive interventions. So if you have a kid who's just upset and they're running up into the hallway and they have like ADHD and a ton of energy, we give them a different activity to do. Right? Hey, sit here, not maybe a sit still activity, but like, hey, let's go to the gym. Let's run around outside where it's appropriate. If someone starts to get aggressive, we try to verbally de-escalate first. We offer medications. Sometimes you see timeout or quiet rooms, more so kind of like a seclusion room where you don't shut the door. Hey, here's some calming music. Here's a book. Here's something that you like to do. Go sit in this quiet area on your own. And as a last resort to keep everyone safe, even in peds, we use seclusion and restraint. So communication and motor disorders. Receptive language disorder, this is where there's difficulty understanding. You struggle to receive the language of others. An expressive language disorder, you have trouble communicating. Whether it's forming sentences or choosing the right word, it's just not possible for this patient. Social communication disorder, there's difficulty using verbal and nonverbal communication, more so in social interactions. It's kind of a hallmark of autism. We see that. A developmental coordination disorder is exactly what it sounds like, impairment in motor development. These kids are not meeting milestones. This is a kid who's going into kindergarten and they're struggling to hold a pencil and write because they can't do that coordination. Or skipping or jumping, straight in the air on 2 feet and coming down on 2 feet. All of those are developmental milestones that kids should be meeting, and in developmental coordination disorder, the kids don't. So a tic disorder. A tic disorder is a sudden, rapid movement. Could be vocalizations, but this follows more. We see movements more often. It occurs before the age of 18, usually between 4 and 6, and it's basically caused by a nervous system disorder. There's an abnormal flow of electricity that causes this involuntary muscle contraction. And what we see more often with the tic disorder is Tourette's. Stimulants increase the severity. You have these repetitive, non-voluntary movements and vocalizations. It is not all cursing, right? We watched the clip from that Hallmark movie yesterday. They're not always aware of the tic. There's a lot of shame. There's a lot of doubt. There's a lot of it's hard for these patients. There's a lot of attention called to them, right? In the clip we watched, there was the dad, and the son's doing the tic, and the dad's like cursing, hitting him, like, why don't you stop it? Why are you still doing it? An important thing to remember when we're looking at these tic disorders, specifically Tourette's, the tic can change. If someone has more of a movement tic, it can change to a vocalization over time. They do not always stay the same. So we just got to be aware when we have a patient who has these. That was the clip we watched from that Hallmark movie. I know some of y'all were asking about it. If you just Google Hallmark movie teacher with Tourette's, it pops right in up. It's called front of the class. I never remember the name of it. So learning disabilities. Bunch of disorders fall kind of under this umbrella, and it affects any way that you understand or use or process or retain how your brain organizes any information. So some specific learning disorders, dyslexia, that's reading words. So sometimes these patients, the words, letters are going to be flipped upside down in order, kind of like their eyes are playing tricks on them. Dyscalculia specifically is related to difficulty with mathematics. And dysgraphia is writing expressions. And dysgraphia is one where it's important to know normal developmental milestones. Children, in kindergarten, first grade, when they're learning to write, it's common for them to reverse their letters, write things in different sizes. An individual with dysgraphia, it continues and they don't grow out of it. Intellectual disability is going to be a low IQ. Usually we classify it by number under 70, but we got to take a look at that kid. And usually in an intellectual disability, we see problems across the board. Problem solving, abstract thinking, social interactions, and sometimes they can't do appropriate activities of daily living. I say it's important to look at the kid because if you have someone who's right at like 68 for an IQ, they might be really good at some things. So we have to look and treat that specific kid. Autism spectrum disorder, we have talked about a lot this quarter. It is a neurobiological and developmental disability. It usually occurs during the first 3 years. There are some early signs, occasionally before 3 years, but you kind of have like a normal development. Pediatrician screens super early for this nowadays. And autism affects social interaction and communication skills. Some individuals, right, we have that spectrum of it, have no communication skills. They just are nonverbal. Some can communicate really well. They're just kind of socially awkward. So it is a spectrum, and we're going to have to see where our patient is on that spectrum, and that's how we treat them. We're going to ignore this because this is outdated, and we have a different one in a few slides. So what we see in autism spectrum disorder, kind of what we said in infancy, might not be making eye contact. They might have a flat affect even as an infant, not respond to their name. In puberty, we either see improvement or deterioration, but most important is early intervention. Getting involved early, speech therapy, occupational therapy, feeding therapy, all sorts of things can help kind of progress through a lot of this. bunch of early interventions program. Texas Early Childhood Intervention is one run through a few organizations. They come out to your house, they do a free evaluation of your kid, and they will even come and do services in the home or at daycare if the child qualifies. You also, starting at age 3, because that's the cutoff age for early childhood intervention, can get a kid into a school district early. And the school district, kind of a Head Start program, will provide services for the child, even speech therapy. Pharmacological interventions are based on symptoms management. If a child's aggressive, we might give a mood stabilizer to help kind of even them out. If there are sleep disturbances, we might give melatonin or something for sleep. And what's going to demonstrate success? Across the board, we always want safety. And that is something we tend to forget about in autism. But autism specific, we're going to want a better social relationship. Are they able to carry on a conversation? Are they able to start? Are they able to take turns with someone playing a board game? So looking a lot at that social interaction, the communication skills, specifically for autism. This is more what you see as the 3 functional levels of autism. Level 1 requires some support, level 2 requires a little bit more, and level 3 is going to require greater support. And it goes from everything from initiating social interactions, narrowed, what the special interests are, nonverbal, but then also organization, being able to problem solve, having repetitive behaviors, struggling with changes. And you can see kind of some of those, the difficulty changing action or focus in level 3. You can still see some of that in level 1. It's going to vary depending on the child. ADHD. Most of y'all probably are familiar with this, right? Inappropriate inattention, impulsivity. These are kids who got ants in their pants and they just can't stay still. They cannot focus. ADD has that lack of hyperactivity. They can sit still a little bit, but they're not paying as much of attention. Present in at least 2 settings. So if the parents are saying this is an issue and it's also an issue at school, great. Sometimes it's only an issue at school. And it could be that there's other things going on in school. These patients tend to have, especially in pediatric patients, right, labile mood, poor school performance, and the poor school performance and a lot of this labile mood, struggles with peers, low self-esteem is what's going to get these kids into treatment. We need to have the family actively engaged in therapy, and we need to make sure the home environment is consistent, structured, and nurturing. Kids with any of these developmental aids do better with a structured routine. And we want to promote achievement of normal development. That's our goal for all of these kids, right? We want them to do at school. We want them to be able to participate in activities, right? When we talk about techniques for managing disruptive behaviors, right? Just like our Alzheimer's patients, there's no difference sometimes between our very old and our younger, right? If we have 2 Alzheimer's patients who are getting frustrated with each other, we're going to redirect them to a different activity. Same thing with one of these kids. If they're struggling to sit still, let them walk up and down. Right? Put an exercise ball instead of a chair. Let them take kind of like a brain break. Get up, move around for a little bit, come back and work on the task to help them focus. Stimulants. You have 2 types of meds for ADHD. Our stimulants, which are going to be like giving your kid meth, but prescription meth, and our non-stimulants, right? So methylphenidate, that is a CNS stimulant, right? Your Adderall, your Ritalin, your Concerta. These, you can often see a dramatic, you give the kid a pill and it works right away. It's not like wait 2 to 4 weeks and see if it works. However, lots of side effects with these stimulants, right? And when we're thinking of side effects of stimulants, we think of side effects of what do we think of with a patient on meth? Insomnia, appetite suppression, headaches, abdominal pain, lethargy. These kids are on their own growth curve sometimes. They fall off where they were. We often will take breaks and hold the medication in the summer or on weekends to give the kid to catch up to their growth curve. That abdominal pain too can keep them from eating. So we have to watch it. Non-stimulants. Sometimes we can't give a stimulant because of anxiety or substance abuse or even a tic disorder. Stimulants will make that Tourette's worse. Or maybe we have a family member who has a substance abuse. Strattera is one non-stimulant. You also see clonidine sometimes used for pediatric patients for ADHD. Your non-stimulants like Strattera, though, kind of some of the same side effects, that GI upset, the weight loss, dizziness, fatigue, insomnia, increased heart rate and blood pressure, which I like how they put it for non-stimulants, but you do see that increased blood pressure and heart rate with stimulants too. And we have to watch with some of those non-stimulants specifically for ADHD meds because they can cause that suicidal ideation, especially in depression, kind of just like you would expect your SSRIs to. So how do we know these kids are meeting their needs? We have to look at the symptoms and the severity, right? Were they failing a class and now they have a C? That's progress. Are they able to sit still for a little bit longer? Are they able to follow directions on the second prompt? Can they follow multi-step directions, right? If I can say, go to your room and get your shoes, that's a two-step direction. If I tell these kids, hey, can you go to your room, choose what you want to wear, grab your socks, get dressed, bring the dirty laundry downstairs, and then get your shoes on, that's a lot of steps, and some of these kids struggle with it. So that's a good way to focus on how they're doing. We have to look at medication administration. Are the families giving the medications? Are there any side effects? How are they doing? Are these kids safe, right? Impulsivity and ADHD, are they eloping from school? Same thing with autism. How is the family doing? A lot of families they're hesitant to seek out evaluation. Oh, there's nothing wrong with my child. You're being, silly. Don't talk like that. So we have to make sure the family's on board, that they're providing support, right? That's that family therapy piece. And make sure the family's connected for additional resources, because sometimes it's hard to make sure all of those pieces connect. Here's a bunch of videos and websites in case you're interested in learning more about all of these. And impulse control. Almost forgot about these. Impulse control disorders, we all have impulse control disorders. I want this and I want it now. And you kind of just can't help it. When we don't talk about it in this class, it's kleptomania, right? Winona Ryder has absolutely no reason to be stealing and picking stuff off the shelves. She's got the money, but she still does it. She can't stop that impulse. Specifically in these pediatric patients, we see a few more hallmark just to these patients. So specifically in these pediatric patients, it's ways of how they're relating to others that's also often involved. And usually these kids are involved in the criminal justice system. It gets to that point and it can lead to isolation. So we have 3 different types of these impulse control disorder. Oppositional defiant disorder. These are kids who just don't like to answer no. They're difficult, they're defiant, they're rude, they're angry and irritable. They like rewards. They don't always care about penalties. These kids can grow out of it. Can, not always, but they can. Risk factors, right? We talked about those ACEs. We've talked about them a lot. We've talked about attachment, right? Insecure attachment, chaotic, neglectful home life, child abuse, lack of structure. All of those things lead and are a risk factor to oppositional defiant disorder. In the treatment, we look at the family. We help the child manage anger. We improve problem solving, right? Parent training, group therapy, anger management for the kids, provide medications. And with all of these, sometimes we have to tell the family, call 911. If there is a struggle, a friend's daughter has an ex-boyfriend, they're like 14, 15. And there was a situation where they saw the kid and he's yelling and screaming and cursing down the street, and they contacted the mom, and the mom's like, just call 911 next time it happens. Like, we can't do anything else. We've tried. And sometimes that's an option for these kids. We watch these videos. Conduct disorder, right? So we have to remember, we're going to switch too far, too fast. We have to switch our thinking to psych nursing. Conduct disorder, right, may be a predictor for future antisocial personality disorder. And antisocial personality disorder are psychopaths. These are serial killers. These are rapists. And we see a lot of that in conduct disorder. These are more aggressive. They do not care about the rights of others. They don't care about society's norms. They don't care about the laws. They don't care about the rules. They're going to go and bust into car windows to steal like an iPhone charger because why not? They're going to kill the family pet. We assess for some of this conduct disorder in pediatric patients by asking about a history of killing, pets at home. They're abnormally aggressive and they want to intimidate, they want to hurt others, and they just don't care about you. They don't care about your rights. They don't care about society's rules, what's expected behavior. They like the excitement. They don't care about the consequences. There's no remorse with these patients. You see a whole bunch, it's kind of like a subset with callous, and they're unemotional, and those are more likely to be dangerous. We see this a lot with parental rejection, neglect, and harsh discipline, right? So when we talk about like spanking be a good thing, and I'm not saying don't spank your kids, sometimes there's a point in time, but harsher discipline at home leads to conduct disorder, or it can. Treatment needs parental involvement. This is a long, intensive process. However, if the parents have antisocial traits, the parents aren't going to see that anything's wrong with their child. Right? This kid, right? He's like, it was an accident. The mom's like, you doused a barn in 2 gallons of gasoline. You've put cement in the gas tank of a teacher. And he's laughing and he's like, it's no big deal. He just doesn't care about the rights of others. And it's not letting me skip this video. Okay. So conduct disorder continued. 2 types, childhood onset and adolescent onset. And it's just what it sounds like. Childhood onset is before the age of 10. Little concern for others, no remorse, right? They deserved it. They have low self-esteem. And this will continue. If you have it in childhood, it's likely to continue to adolescence. And if you don't stop it, it develops into an antisocial personality disorder by adulthood. Adolescent onset, right? No symptoms before age of, usually that's like 10 or 11. And we see them acting out a little bit differently, right? We see sexual behaviors, we see substance abuse, high risk taking. Girls more so are going to lie, be truant, run away, have a lot of promiscuity. So in telling the difference between the two, oppositional defiant disorder, more conflict with authority in adults, that emotional dysregulation, temper tantrum outbursts, and they can grow out of it. Oppositional defiant disorder is a lot of angry and irritableness. Conduct disorder is dangerous. You have the conflict. However, aggression toward people and animals, theft, right? They're going to bust windows. They're going to break into somewhere to steal something stupid. They're going to spray paint and tag. Callousness is a huge predictor of when we look at that aggression and that more seriousness of it. But then untreated conduct disorder, you don't grow out of it. You turn into an antisocial adult. Intermittent explosive disorder, right? Miss Julie's brain, she's in the Army. We got an IED, which is like that roadside bomb. And all of a sudden you're driving, everything's peaceful, and a bomb goes off. That's intermittent explosive disorder. It's an inability to control aggressive behaviors. There could be a trigger. There could not be a trigger. It could be targeted towards people, person, property themselves. And you get this rage, this explosive behavior, and then you have remorse. It obviously causes interpersonal problems. We watched the video in the class where this kid is just raging, screaming at his mother about something stepdad did. It leads to hypertension and diabetes. And we see this more with exposure to violence at a young age or a history of sexual or physical abuse in children. We need to do psychotherapy. We can do pharmacology, right? Different kind of mood stabilizers to help stabilize that mood. But these are kids who are they can't control. They explode, right? Here's this guy, apologize for all the curse words. He just rages. In assessing these with kids, we still have to look at a suicide risk. It's possible it happens with all of them, right? Is there a history of a suicide attempt? Because impulsivity is a risk factor for suicide. What's their judgment like? Are they using drugs and alcohols? Are they compliant with treatment? There's different screening tools, right? Never, sometimes, often. How do they do? And we look at a self-assessment from the kids. Again, we want input from the family, from teachers. If this is just a problem at home and the teachers are like, he's a perfect little angel, we want to look at more what's going on between the kid and the parents. Safety for the patient and everyone else. Establish a rapport with the patient. Set limits with the patient is huge. Let them know what they can and cannot get away with. If there's consequences, we have to follow through. It's not just like, well, one more turn. No, you did this, so this is the response, the consequence, that is it. Structure and boundaries, right? Activities that they like. Individual, group, and family therapy treatment. We need to teach the family to set consistent limits. We're going to use pharmacological choices that can treat aggression, right? Maybe it's mood stabilizer. Look at what's going on and be really involved with intensive therapy. Behavior contracts. If you do this, this is the end result. If you do this, this is what happens, right? Counseling, we want to role model good behavior. Planned ignoring. If you're throwing a temper tantrum, I'm going to walk away and not pay attention to you. I'm going to keep an eye on you. I'm going to make sure you're safe, but I'm not going to feed into this temper tantrum. We want to keep physical distance, right? I want to be 2 arms lengths away. I want to be 2 leg lengths away from this patient. Redirect them while they're still redirectable to a different activity to help, maybe a calmer activity, maybe one work that, it's a little bit okay. You don't want to go throw this person into a game of basketball with a group of people. They'll be throwing elbows and taking people out, but maybe like horse by themselves or like a one-on-one type game where they can be a little bit chiller. Give them positive feedback when they're doing good things. Look at the restructuring of the environment, setting limits, right? Simple restitutions. Well, you broke this person's phone, you got angry, you threw it on the floor and stomped on it. You need to go buy them a new phone. And as a last resort, physical restraint or seclusion. In families, that's not always possible, right? That one kid who was raging, yelling at his mom, he's a big kid. Tell the family to call 911 if it's at home. We're going to do this later, so we're going to pause here. If y'all have questions, let me know. Otherwise, hope you'll have an awesome day.